Good morning and welcome to our annual Public Policy Forum in Connecticut. Today we're focused on lung cancer prevention, screenings, and treatment. My name is Bill Sherman. I'm the Managing Director for the American Cancer Society Cancer Action Network, or ACS CAN, as we call ourselves. I cover the Northeast, so Pennsylvania, New York, New Jersey, and all of New England. So I love being up in New England with the amazing things that we are doing in terms of advocacy as it relates to cancer. I'm honored to be with such great leaders and advocates in the fight against cancer. ACS CAN is the nonpartisan advocacy organization of the American Cancer Society, and advocacy has always been a key component in the American Cancer Society's fight against cancer for the past 110 years. After decades of little improvement, recent advancements in screenings and treatment have led to lower mortality rates and longer survival for lung cancer patients. This, coupled with our strong smoke-free laws, has become a game changer for many. This is personal for me. You see, my father passed away of lung cancer at age 58. He told me that he and his mother and my mother started smoking at age 15 because it was easily accessible, and in his words, because it was cool. Everybody was kind of doing it. I think about him every day and wonder how different his and my mother's lives would be if they had the same strong tobacco control programs and protections and the screening and treatment advances that we now are experiencing. In Connecticut, there is much to celebrate. Recent reports place the state near the top of both early diagnosis and survival. Additionally, the state is establishing a lung cancer referral and education program targeting those most disproportionately burdened by the disease, including communities of color and people with lower socioeconomic status. It's a key component for us at ACS and ACS CAN in terms of health disparities. However, now is not the time to take our foot off the gas. In Connecticut, lung cancer is the third most common cancer, yet more than twice as many people die from lung cancer as from any other cancer. This year alone, 2,750 people are expected in Connecticut to be diagnosed with lung cancer, and sadly, more than 1,300 will die from the disease, and this is almost all preventable. More alarmingly, despite coverage being available, lung cancer screenings are not widely employed for a number of reasons. With only 6% utilization rate here in Connecticut, but you should know that's higher than the national average. So even though we're higher than the national average, it's still critically low. We must strive for more, and we still have work to do, which is why we are here today. So today's forum will explore further efforts to promote screening and overcome barriers to access and innovations in treatment, including addressing the stigma that still follows lung cancer. How can Connecticut best position itself to take advantage of the promise and potential of prevention, early detection, and access to innovation? To get us started, I would like to introduce a man who needs no introduction, Dr. Roy Herbst. Dr. Herbst is, among many titles, the Chief of Medical Oncology at the Yale Cancer Center and Smilow Cancer Hospital, and he is nationally recognized for his leadership and expertise in lung cancer treatment and research. He is best known for his work in developmental therapeutics and the personalized therapy of non-small cell lung cancer, in particular the process of linking genetic abnormalities of cancer cells to novel therapies. Please join me in welcoming Dr. Herbst.
Thanks. It's really an honor to be here and to kick this off, and I'm looking forward to the panel. I really appreciate the parking ticket. You know, this is one of the barriers to screening, right? You know, people say they can't park, they can't get in. So we have to talk about that today. You know, access and how we're really going to make screening and prevention, part of our daily lives. So I have 20 minutes, and what I thought I would do is just, get us kicked off. Why is it important to screen? It's important to screen because if we find lung cancer early, we can cure it. And I say that now with a big C. 20 years ago, 25 years ago, when I was finishing my fellowship at Dana-Farber, maybe a little more, I would say we could still cure stage 3A, 3B disease in a few people. But now I think you'll see with targeted therapy and immunotherapy, in the multimodality setting, we can make a difference. So it's important to get these patients in early. It's also important to work on smoking cessation. So my disclosures. So lung cancer is the #1 cause of death worldwide. That's why I see some pharma people here. I see many academics, people from the community, from the government. It's a major health problem, the #1 cause of cancer death. We screen for many years now for prostate cancer and breast. We diagnose more cases there. Of course, skin cancer, that's the quick question. If you're ever at a cocktail party, it's skin cancer. That's the #1 cancer. And look how we can cure many of those. But lung cancer has been a bit behind. But you can see over 200,000 new cases a year in the US with 135,000 deaths. Most of the lung cancer is adenocarcinoma, non-small cell lung cancer, small cell lung cancer, diminishing, but still about 10–15%. Most of that's due to smoking, although we now know that that can transform from some of the driver-mutated cancers. But it's a major problem, #1 cause of cancer death worldwide. Go head out to Asia, to China, Japan. It's a million people. And we don't do too well, or we traditionally have not done so well with lung cancer when it presents in the most advanced stages. This is just 25 years ago, and this is what survival curves look like. Here's overall survival and progression-free survival for patients with lung cancer in the advanced setting with chemotherapy. And many of these chemotherapies, docetaxel, gemcitabine, paclitaxel, they're all generic now, but they were all, the new drugs of the 90s. We were all very excited. They still have an important place, by the way, in cancer treatment. Don't forget, we have to add and work with existing therapies, build on the shoulders. But you can see no one with a long-term survival. The 1-year survival in metastatic lung cancer spread from the lung, non-small cell, 33%, median survival about 7 or 8 months. It really was a pretty gloomy time in the advanced setting, but we've made progress, as I'll show you now. So, we now know that there are many causes of lung cancer, and both equally important to target. There are certainly those who smoke, and we're working on smoking cessation. I'll say a word about that, and we'll talk about that on the panel. But there are many who don't smoke. About 20% of lung cancer patients do not smoke. And you can see all these potentially actionable genetic mutations. And I will predict that if we were here next year, and we will be, I hope, you'll see that many of these mutations now are being targeted in the earlier setting. EGFR was the poster child for this, but ALK and ROS1. KRAS is interesting because that actually occurs more in smokers than non-smokers. So we're even finding mutations in the smokers. But then, of course, we know that in the people that smoke, immunotherapy has really changed the scene. And you just have to watch TV to see that there's immunotherapy for lung cancer. There are commercials that tells you lung cancer therapy is in the mainstream because it works so well. But this is the key slide to get us kicked off for today. We are making a difference. And these are data from probably the most cited paper in all of cancer from the Cancer Journal and the American Cancer Society. It should be credited. You can see in men and women, this is incidence of cancers, and this is deaths per 100,000. This is death, excuse me. Here's lung cancer. You can see going up and up and up and up and up and up. A lot of smoking, about 20-year lag from the peak of smoking. Now it's coming down. And then you can see in women, a little bit more of a lag. Women started smoking a little bit after men. It's going up, but it's also coming down. Why are these rates coming down of death in lung cancer? Twofold. You look here in men, the incidence is going down by 2.6% per year. And by the way, when you get these data, they're always 5 or 6 years old. There's a bit of a lag. So I don't even think we're seeing immunotherapy in this. It's probably more of the targeted therapies. But you can see the incidence is going down. This is screening. But we're going to talk today about how to make that even less. And the mortality, even more than incidence. So that's probably some of the targeted therapies that combine chemoimmunotherapy. And then in women, 1.2% in incidence and 3.1% in mortality. So we are making a difference. So who was it? One of my old-time mentors, Larry Norton, used to say, there's a light at the end of the tunnel. It's just a very long tunnel. So I would say the tunnel is getting shorter. We can see the lights. Now we have to work together as a community. It doesn't matter if we have all these new treatments. It doesn't help enough if we have all this screening, if we don't get people access and into the program. So I'm going to just tell you a little bit about a few things to excite you in the next 10 minutes why it's so important to treat and find new therapies for lung cancer. We have a big program here. This is the Thoracic Oncology program. And here's Dan Baffa, Frank Getterback, two of our surgeons, and you'll be seeing Lynn Tanoue. Actually, Sarah Goldberg leads the program now. She's taken over for me. You can see we have a SPORE. This is a specialized program of research excellence. It's a large grant in lung cancer. So constantly trying to do research in this area. We're targeting new immunotherapy targets, something called Siglec-15. We're looking at resistance to EGFR targeted therapy. That's led by Katie Paletti, Sarah Goldberg, and Mark Lemon. And then we're looking for new ways to target the brain. When we have a couple of patient advocates on our SPORE external advisory board, and they always tell me the thing that they're most worried about is brain metastases, and I get it. So we have to figure out how to target and prevent metastases to the brain. Of course, finding it earlier will be helpful there. And we have cores, and again, I'm not going to take too much time on this for today, but we've now been funded on this grant for 10 years. We're actually spending our holiday writing the third 5-year installment, Katie, myself, and the team. And teamwork, and all of you are part of the team too. And just talking to Peter from Hartford, who I've known for years, we all have to work together. So how can we have the most impact? We have to screen. We have to work on tobacco cessation. I see some of our team here, Brenda, Beth, and others. We have to use these moments when we screen to work on smoking cessation and then improve treatment. I've always thought that screening, for years we were talking about screening. It was a while before we had some of the randomized trials. Screening would help, but if you find an early lung cancer, then you have to figure out what to do about it. And the problem with lung cancer is, I showed you, it's so difficult to treat, even in the metastatic setting, that we have to have better treatments when we find the disease early. So I'm just going to show you a few snippets to get us excited for the panel. Targeted therapy. Well, hard to believe, it's 26 years since I first met my good friend Pat LaRusso. She's right downstairs in the clinic down there if anyone wants to go say hello. She's seeing patients today. She's running our phase 1 program here now. She was at Carmenos at the time, but together we led this trial of a drug called ZD1839. We were the 2 lead investigators. That was the first EGFR inhibitor, oral tyrosine kinase agent, that took patients with lung cancer like this and the widespread metastatic disease. We used to call it bronchoalveolar cancer at the time, and we saw amazing responses. That was the beginning of targeted therapy for lung cancer. Of course, there were data in leukemias and breast cancer before, but that's where lung cancer targeted therapy really began. Then, of course, we learned about the EGFR receptor and the ligand, EGF, or tumor growth factor alpha, a transmembrane receptor, signal transduction through phosphorylation. And lung cancer became a disease in the advanced setting where we could treat it, and I don't think we cure it. Unfortunately, I don't think we cure anyone with these targeted therapies because resistance will always develop. But people can live for years. And this was an article in the Wall Street Journal. This is one of the patients that I cared for in MD Anderson, Sicily, here on the right. That's her husband on the left. And she lived for about 10 years on an oral EGFR TKI. Was she cured? No. But she was taking a drug for lung cancer like you would take a drug for diabetes or for hypertension. But then, just in the last, about 10 years ago, I joined a project, and some of you have been involved. I see some of you in the audience, where we said, well, if these EGFR inhibitors work so well in advanced lung cancer, let's bring them to earlier disease because we know, and this is the problem with lung cancer, stage 1 lung cancer, even if you find it early. One of us trips on the way to our car, but now we don't go to the garage because we have the parking ticket. But if we had to go to the street, it would be a 60 to 74% chance of cure in stage 1, meaning a 30% chance it could recur. Even the earliest lung cancers recur, and we're finding them earlier and earlier now. And stage 2, only 45 to 55% are cured, and stage 3, only 38%. So we have to, and that's actually generous. I think more than that will recur. So we have to do better. So this was a trial, and this is just an example of how screening could help. So if you find a lung cancer earlier, not in stage 4 metastatic, but in stage 1, 2, and 3, this was the ADAURA trial, which has been presented. Actually, it's been at ASCO twice. It was 2 plenary sessions, one in 2000 and one just this last year. And this is a trial where we took patients with lung cancer who had this EGFR mutation, about 10% in the US, 30% in China, Japan. And we cut out their tumor because it was found early, stage 1, 2, or 3. And then we gave them chemotherapy if appropriate. And then they were randomized to the most advanced generation EGFR TKI, osimertinib, for 3 years versus a placebo. Why a placebo? Because nothing else had been shown to benefit in that setting. And this trial was presented, and it was first presented in 2000. And look at the results. Here are patients in yellow who got a control, just the placebo, and here are patients who got 3 years of the targeted therapy. And you can see the hazard ratio here is 0.2. That means an 80% improvement in disease-free survival. The skeptics said, well, it's still early, give us a little bit more time. So we reviewed the results again in 2023 for the disease-free survival. And you can see the hazard ratio here is 0.27. So a 73% improvement, patients who got the targeted therapy versus the control. So by finding the lung cancer early, treating with new targeted therapies, we can make a difference. Screening is important. And then this year at ASCO, we got the survival because there, many people say, and we can talk, there's some patient advocates here, I think disease-free survival is pretty damn good because you prevent the metastases to the brain, the liver, the bones, but certainly you want to see overall survival as well, and the overall survival was presented this year at the ASCO. I was fortunate to present it, and it got published, 0.49, meaning a 51% improvement in survival. And if, Monica Bertinoli, who's now the NIH director, but as the NCI director, she was talking about 50% improvement in outcome for survival. This is just one small snippet of cancer, but I think we've hit it, and I was very fortunate, and I don't know if Eric's going to stop by, our cancer center director, but he certainly has been so supportive, and we actually, it was very nice to be on the podium with him at the ASCO plenary, and Kimmy Ng. So biology has really spoken. This is one of my old former mentors, Josh Fidler, who sadly passed away a few years ago, but always talked about metastases. It's metastases that kill patients. So if we can block the metastases and take our best surgery and adjuvant therapy and then targeted therapy and use them all together, we can prevent patients from having metastases and they'll live longer. And then other drivers, I just want to point out that now there's a trial called ALINA. It's not FDA approved yet, but ALINA was looking at alectinib in a very similar setting. And we saw from Ben Solomon at the ESMO just about a month ago that here's patients who get alectinib after surgery in the early stage versus a control chemotherapy. And you can see the same thing. It's a new paradigm. Early detection, earlier treatment, treat with the targeted agent. So now in the last 5 minutes, immunotherapy, how can I not talk about immunotherapy and its impact? Immunotherapy really has many of its home here in Connecticut with Mario Snow, Scott Gettinger, Harriet Kluger, and others doing the earliest trials. We know that immunotherapy reactivates the immune system to target tumors. And we are actually very fortunate. Scott, who may or may not stop by this morning, but Scott in 2010 saw Maureen, and this is Maureen a few years after that, but who came in with really horrible lung cancer, and she's allowed us to use her story. 3 times refractory squamous cancer. This was actually not, the squamous cancers almost never have one of these targetable mutations. And look at the disease in the lung, tremendous disease. And, we were doing the first trial of MDX-1106 with BMS. And, of course, they were located right up the street in Wallingford. Well, not right up the street, but not too far. And you can see within weeks, she had wonderful response. And actually, she's still alive. In fact, she showed up, she was in the clinic the other day, so I took a picture. And there she is. And she's alive 13 years later. She was allowed, and there's her husband, living good quality of life. It's only 15%. So if we found patients earlier, it could make a difference. Let me show you. So we know that in this trial, and there's Scott. There's a very young picture of Scott. I need a better picture. It's like his bar mitzvah picture, But I keep asking him for a new one. But you can see he's been a pioneer in this field. 16, and Marianne Daves, who's here, has been working with him since then. You can see 5-year survival, 16%, actuarial survival. But we got to get that better. And I would contest if we find the cancers earlier, we'll do better. So it's this tail of the curve. We want to increase that. And then brain metastases. So I put this in last night because I saw Jimmy Carter on TV last night, and amazing, he's still alive. But 10 years ago, Harriet was doing this study with Sarah and Veronica. You'll see how I make the link in a second, where we were treating brain mets. It was the first IIT where we got Merck to give us an IIT so that we could treat untreated brain mets with very close MRI with pembrolizumab. And when Jimmy Carter, who's now lived like 5-10 years with melanoma to his brain, they called, Wally Curran called and said, do you have any data? And we were able to share some of these data. So it's incredible. These drugs even work in the brain. So why is it important? If you find the cancer early, you can prevent the brain mets. But if you have the brain mets, you can use immunotherapy without radiation in some patients so that when patients live, they live with better quality of life because they avoid any cognitive impairment they might have from radiation. So precision medicine definitely helps. I'm running out of time, but we have to biopsy, we have to learn, we have to use science. Neoadjuvant therapy, this is the point I want to make now. Now we know that if we can treat earlier with neoadjuvant therapy, we give the immunotherapy, chemotherapy before surgery, we can, 20-25% of tumors will be totally dead. we can really have an impact. So now the whole idea is that instead of taking a tumor out and treating with immunotherapy, you treat when the tumor is in its normal microenvironment. So all the T cells move through the lymph nodes, so you have a much better efficacy. And I think many of you know this story, but this is a trial, I just showed one of them for the sake of time, called the Aegean study, looking at durvalumab plus chemotherapy in the neoadjuvant setting. And you can see these are patients who have a pathologic CR, 17% versus 4% of patients. There's no tumor seen. The surgeons will tell you, Roy, it's just melted away. And the surgeons have all bought into this. So this is now becoming a standard of care. There are 4 different drugs that have shown positive results. Here are patients who get neoadjuvant immunotherapy versus those who don't. So we can only do this if we find the cancer before it's spread, only if we screen. And then I actually wrote a nice editorial with Mena Wang and Li Ping, when immunotherapy meets surgery. So it's like we're bringing it all together. That's what we have to do, bring it all together. So tumor board, this I got off the web. This is the way I wish my tumor board worked. You know, everyone's there, they're in their white coats. I think this is probably from, who knows, it's probably staged. But this is the thing. What approach? Surgery, chemoradiation, adjuvant, neoadjuvant, which agents? We are all part of networks here. I've spoken to some of you before the meeting. We have to have tumor boards. We have to treat. We all have to come together and have a plan at the beginning, but we have all these options because we're finding cancer earlier. Want to see what our tumor board looks like? But if you get there are plenty of muffins because no one's, the muffins are in the corner. People have gotten to the Zoom. I have a mixed feeling on that. I think it brings a sense of community together on Zoom, but there's nothing better than just all being here in this room today. So we have to get back to a new world. So the future, a lot of drugs have been developed. We have to do clinical studies. All of us in Connecticut do clinical studies. I'd love for us to all collaborate and work together. We need to target immunotherapy. We're just at the very, very, very tip of the iceberg of what we're doing with immunotherapy. When people fail immunotherapy, we give them all a protocol or a drug. We need to understand is why do they fail and what's the precision of immunotherapy, and that's going to be the next few years. There are many resistance mechanisms. So understanding resistance to immunotherapy, that's going to be something that we do resistance work with, we do research with. We can do more of that, by the way, if we find the cancers early. In the neoadjuvant setting, we've given immunotherapy and then we cut out the whole tumor, take that tumor and analyze it in the labs, and then we can figure out what we need to do next. Just a slide to show this is Li Ping Chen. He's one of the fathers of immunotherapy, as I think many of you know. He's got a big lab on the West Campus, exit 42 down there on 95. But there are new checkpoints and new targets, and that's some of what we do here at Yale. And then lastly, this is a labor of love for me. It's called the Lung Cancer Master Protocol. I truly believe public-private partnerships. What we really have today is a public-private partnership. We have industry, we have academia, we have foundations, we have multiple hospital systems together. Only if we all work together as a team are we going to run trials, and I would say we need more master protocols. Pragmatic, easy trials, easy to get on, easy to open, new drugs, getting them to the point of care, getting them to the community. This is a lung cancer master protocol we've been doing, and I work very closely with my friend Ellen Siegel at Friends of Cancer Research. We've done this now for the last 11 years. And I would say that what we need to do is find ways that patients can come in and we can profile their tumor at the get-go, and by the way, do it for free in this private-public partnership. The money comes in from the industry. It's free, the screening, so anyone can get the screening, and offer them trials either based on a biomarker or based on other characteristics of the tumor. So this type of trial can be open in the community. Most patients are taken care of in the community. We have to go to the point of care to treat those patients. And diversity is very important, and we just actually published an article. 24% of patients are more diverse than the standard, which I think is important because rurality, getting trials to the rural area, not everyone can get in a car. Not everyone gets this free parking here. So these are very important things. We've got to get the trials to where people are located. So this is just a bit of showing that it's a team. Teamwork is critical, just about done. So where's the future of lung cancer? My last slide. We need to personalize immunotherapy. We need to identify biomarkers and improve combination therapy. We need to identify new targets and rational combinations. We need to establish novel endpoints. We need innovative trial designs. We need to address mechanisms of resistance, but I left it last for least, early diagnosis through effective screening and management of disease. So early detection is critical. We have a translational lung cancer series here. We're constantly looking for new, people come here, this is a good lunch, so everyone comes for lunch, and it's a little later in the day. But we really have to do more. And with that, I'll thank you. The one last thing I want to point out, you're all invited, June 12th and 13th. Katie Paletti and I, along with our lung support team and with Eric in the hospital, are hosting a 20-year anniversary of the discovery of EGFR mutations. We're going to have Harold Varmus will be here, I hope, and we're going to have an amazing panel to discuss how this all evolved and how we can do even more for lung cancer patients in the future. So with that, I'll stop, and thank you very much.
Well, thank you, Dr. Herbst. Just so exciting about targeted therapy, immunotherapy, but also what I was struck by is what we talk about at the American Cancer Society as well, is treating cancer as a chronic disease, right? Where I remember when the threat of cancer or the diagnosis of cancer felt like an immediate death sentence, and now we're really focused, along with all of our partners and many of you here in this room, where just like heart disease, it's something that people can live with, and quality of life is improving as well as along with the length of life. But the key is early detection, right? The key is catching it quickly or hopefully preventing it altogether. I want to highlight that just this month, actually October 31st, the American Cancer Society updated its lung cancer screening guidelines for people at high risk due to smoking history. So ACS recommends adults aged 50 to 80, unfortunately I'm now in that category, receive screening if they currently smoke or used to smoke in the past and have a smoking history of 20 or more pack years. So what's a pack year? A pack year is equal to smoking 1 pack or about 20 cigarettes per day for a year. Okay, so for example, a person could have a 20-pack year history by smoking 1 pack a day for 20 years, or 2 packs a day for 10 years, okay, to kind of make that a little simpler. I also want to direct you to what we handed out in our with our programs, that sheet of paper, because just last week, ACS CAN released our new position to eliminate patient costs for lung cancer screening and follow-up tests. So Dr. Herbst was talking about the barriers to screening, but also to treatment. And what we see is if there is out-of-pocket costs there, and some companies are identifying, follow-up costs as not part of the screening, ACS and ACS CAN say that that is part of the screening. And so our goal is to eliminate the barriers to screening and early detection. Well, now I'd like to continue the program by next introducing Lucinda Hogarty, the Executive Director of the Connecticut Cancer Partnership. Since its establishment in 2002, the Connecticut Cancer Partnership has grown from a core group of 5 organizations to a broad and diverse coalition, more than 300 strong, representing elements of the cancer community from all across Connecticut. Lucinda took on her role as the director of the partnership in 2008. And as its first director, she has overseen the development and implementation of 3 multi-year state cancer plans, including the current plan for the years 2021 through 2026, which she will discuss today through the context of lung cancer screening. Please welcome Lucinda.
Good morning. While my slides are being brought up, I don't know if there's a little technical step I'm supposed to take here. I just want to thank you so much for giving me the opportunity to talk to you. Many of the things that Dr. Herbst talked about resonate with what we'll be discussing in the collaborative partnership approach. Thank you, Emily. The Connecticut Cancer Partnership is, as we just heard, the concept of comprehensive cancer control coalitions at the state level began in Connecticut in around 2002. Thank you. It was developed in the That's working now, right? Yeah. It was developed by the CDC in the late 90s and was introduced with a core group of participants from key organizations here in Connecticut in 2002-2003. The staffing is provided through contracts and with the Connecticut Department of Public Health. Funding comes from the CDC to DPH, and the requirements are that the Department of Public Health oversee the development of state cancer plans and the existence of a cancer coalition, which Bill just mentioned. Voluntary membership is drawn from the state's cancer control community, broadly defined. Members are the ones who develop and implement the state plan through work groups, which determine the strategies to implement annually. And I'm going to focus on lung cancer today. What does the partnership do? Within the context of the state cancer plan, and this is a hard copy of our state cancer plan, it's available on our website, and the advantages of having it on the website are it's a 75-page document, but you can navigate to the area of interest. So we're talking today about early detection and screening. But within the context of the state cancer plan, the partnership's role is to convene, to educate, mobilize advocacy for policy systems and environmental change, monitor data trends, which are key, disseminate best practices, so that they can be shared, and promote the implementation of evidence-based interventions. The 5 founding members which were mentioned are the American Cancer Society, the Yukon Health Center, the Yale Cancer Center, the State Medical Society, and the Department of Public Health. They established the initial structure back in the early 2000s. Funding actually started to be received from the CDC in 2005, and there have been a total of 4 multi-year state cancer plans since the first one in 2006. Every once in a while, there are state appropriations in addition to federal funding, and those have been able to support some of our initiatives. There was a period of dormancy in the late teens due to some restructuring, formatting, and due to COVID. But we're back and going strong and introducing new activities since 2021, during which time we've re-energized the membership, drawing to a great extent on the previous members who I had worked with when I started back in 2008, and then many new members have come in. I've worked closely with ACS CAN during that whole time. But since 2021, we've introduced the new plan, and at last year's annual meeting, just a year ago, we selected the 2023 initiatives based on member interest, one of which was lung cancer screening. The other one, in case you're curious, is HPV vaccination. So we had one for prevention and one for early detection. Addressing the lung cancer screening issue, the coalition approach, which involved members from all of the health systems across the state and professionals working across the spectrum of involvement, we've been able to coordinate work in strategic initiatives across these silos and sectors, identified specific gaps for specific groups or geographical areas, have done a great deal of new relationship building, and we have been involved in education and advocacy on cancer-related policy. So the lung cancer screening work group, and Jean Brown is here. There's Jean, and she has been key in bringing these people together with her background and knowledge of the field and of key players. We convened just last March for the first time, we convened a large and active work group of physicians, nurses, community health workers, navigators, researchers, students, all of whom bring a passion to the work of lung cancer screening, recognizing, as Dr. Herbst was saying, that the earlier the disease is diagnosed, the better the outcomes. They quickly started to recognizing the low screening percentage of eligibles, 6% or so, started to develop unified messaging, avoiding corporate rivalry. We didn't want it to be, oh, Hartford Healthcare does this, but Yale doesn't. Get the word out across the board, across the state, that lung cancer screening can save lives. They chose actionable strategies from the cancer plan to implement. That's where the rubber meets the road, sharing content and best practices to streamline effort and to avoid recreating the wheel. So, about the plan. The plan has goals, objectives, and implementation strategies. It's, as I mentioned, 75-page document. We do not see it as a report. We see it as a blueprint for action. Strategies are actionable items that work groups focus on depending on their members' own interests. We only choose strategies, and there's many more than we could ever accomplish in the length of the 5-year cancer plan. But if we have a core group of people who are interested, that's where the energy comes from. The plan flows from lofty goals across the continuum of cancer control to specific objectives, many of which are data-based, to actionable strategies. Goal 1, just to focus on that, which is the overarching goal, imbuing all of the others, is to promote, advance, and improve health equity, recognizing that overall, Connecticut might look like we're in good shape, but when you drill down into specific areas or populations, there's a lot of work that needs to be done. So our priority areas under this goal are healthcare access and quality, community, clinical linkages, which is the one I think that the lung cancer work group has worked on primarily, and workforce and education. Goal 2 is prevention, but we're going to focus on Goal 3. The Goal 3 reads increased screening and early detection of cancer across all the anatomical cancer sites. And screening for each one of the cancer sites, of course, addresses social determinants of health, issues around access, equity, community trust, cultural issues, and geography. The lung cancer screening objectives were drawn from our tumor registry and our epidemiologists looking at percentages that are baseline and where we want to go, what are our targets. So the first one, as you can see, addresses screening. And that 7.6 is probably pretty high in terms of the eligibles who are actually screened. We do hope to continue to see behavioral risk factor surveillance system questions asked about lung cancer screening. Of course, decrease the rate of late-stage diagnosis for lung cancer and decrease the mortality rate in the state. Very data-oriented and measurable only over the long term. But what did the work group do? Once we convened and recognized that we had representatives from across the state who were passionate about improving that data in terms of the percentage of lung cancer screening. Very early on, in March and April, we oversaw testimony being provided to the legislature about biomarker screening, including lung and breast cancer. We did a press release demonstrating the one voice, speaking from the health systems across the state, supporting messaging about lung cancer screening. And we republished an article with permission on our website as part of our emerging issues brief about one of the biggest barriers with lung cancer screening, which is stigma, blame, and shame. And that's something that all the participants in our work group repeatedly tell us is such an issue. People feel they're not entitled to screening because they're still smoking. And that's where we have worked, I'll talk in a second, about working with smoking cessation as well. Some of the work group activities focused in on some of these initiatives or issues that I just talked about. Windham County, we formed a subgroup with some support from the American Cancer Society's Get Screened initiative, which came about after COVID, and it was Get Back to Screening, but now it's Get Screened. using direct-to-consumer messaging where in northeastern Connecticut, where the data showed us the needs were very high. This is a geographic area that had high smoking rates, high late-stage diagnosis rate, and low access to services, with some of the issues being geography in terms of parking and transportation. A smoking cessation group formed quite quickly, working with the state quit line and with other quit programs to incorporate screening information into the registration process. We were surprised. We were very surprised early on in this process when we talked with representatives from systems or the state quit line programs. What information do you give to your smokers who have expressed an interest in quitting about lung cancer screening? And we found out information was not being given. This was a primary group. They were already motivated. They were doing something to improve their health. They wanted to stop smoking. And as of actually just this past week, the state quit line has incorporated a new section that was developed through the work of this subgroup. So that has just gone live. Jean, I just found that out, actually. So this is something we've been working on since March. And this modification has been put in place through the state website. It's also been picked up by some of the independent smoking cessation programs that are run by hospitals or health systems. We also recognize that one of the barriers is people who might say, yeah, I probably should talk to my doctor about lung cancer screening, but where would I get that done? We found out, delving into a lot of resources, that the lists were not comprehensive. It looked like you might have to travel to Hartford, but you could actually go to a local site in Willimantic. So we developed a very comprehensive list, which is also now on the state website and has been circulated to all the health districts and health departments in the state. Today, November 30th, is the last day of Lung Cancer Awareness Month. And so earlier on in the month, we provided lots of resource material to our health districts, who often will promote whatever the focus of the month is. And this month it was lung cancer screening. One of the other things we did was the members of our group, Dr. Alana Richmond, who's a primary care provider, created a short video. It is narrated, there's subtitles in English, and we added subtitles in Spanish as well. 2 minutes, that is also now on the website that I just mentioned, the State Quit Line website, that talks about why patients should consider talking to their doctor about lung cancer screening. It's being widely disseminated. She's been very generous with use it for on a loop in provider offices or in whatever electronic media you may want to use it for. Also during the month, we shared the compilation of the lung cancer activities from across the state to encourage consistent messaging, have market saturation, get the word out. We've been hoping that lung cancer is as identifiable with the month of November, or November's as identifiable with lung cancer as breast cancer in October are. We have a long way to go, but with this kind of getting the word out through the initiatives I've just talked about, it's one way we hope to get there and raise those numbers, have more people talking to their doctor as far as their eligibility for lung cancer screening. New linkages have developed within the lung cancer screening work group, which has been very exciting for the overall partnership. We've engaged community health centers much more than ever before. I mentioned the health districts and departments. We have a number of students, medical students and undergraduates, dental students, representatives from underserved communities, which is something we've always wanted to work on. We have very strong data support, which is critical. We've engaged much more pharmacy engagement, both through local small stores, big box stores, and the pharmacy training programs through UConn School of Pharmacy, and pharmaceutical companies. The success of the lung cancer work group absolutely depended on the engagement of these new partners. So I think all of these activities that I've just discussed demonstrate that statewide collaboration is an effective and powerful approach to meeting the changing challenges of cancer. This collaboration will be the topic of our annual meeting, which is coming up 2 weeks from yesterday, Collaboration in Cancer Control. And we would love to see, I know many of you already have registered, which is wonderful, but it's going to be December 13th at the Sheraton South in Rocky Hill, and you can register on our website and get involved in some of the new initiatives that we'll be rolling out for 2024, one of which will be a survivorship initiative for early onset cancer patients and survivors, as well as one on prostate. So thank you very much. I appreciate it, and I hope to see your involvement with the Cancer Partnership moving forward. Thank you.
Well, thank you, Lucinda. What a great partnership the partnership is, and what a great resource you are to the community. The comprehensive cancer plans in all of our states and here in Connecticut is really the recipe, and it's the map for how we address cancer within the state. So I just think it's so important. Thank you for your leadership and for the work there. So now we want to kick off our roundtable, and I'll note that Dr. Herbst stayed, and he said he's ready for questions, to be asking the questions of panelists. So get ready, because he's on his game. I want to introduce someone who brings a set of brains to the Senate, and if you know, my job is working with the state legislatures, and sometimes that's not around the state capitals or the state houses very often, but he also brings real life experience. So I'd like to introduce State Senator Jeffrey Gordon, who represents the 35th Senate District in Northeast Connecticut. Senator Gordon is also Dr. Gordon. And so I'm going to call him Dr. Senator Gordon, because I think, first of all, doctor has a little higher esteem, no offense to the Senate. But certainly I would guess that becoming doctor was harder, although, you know, getting elected nowadays is pretty difficult too. So Dr. Senator Gordon brings over 28 years of direct patient care experience as a physician specializing in cancers and blood disorders. He has served in many hospital leadership roles and statewide capacities, including as a medical director of hematology oncology services. He's the moderator of the tumor boards. Hopefully his tumor board is a little bit busier or more attendees than Dr. Herbst showed on his slide. He's also, as president of the Connecticut State Medical Society and a member of the Connecticut Medical Examining Board. With that, I'll turn the program over to Dr. Senator Gordon and our panelists.
Good morning, everybody. I'm very happy and proud to be here. I can't beat that type of introduction, and I hope that you can actually join me every time I'm in the Senate chamber, because you can introduce me when I get recognized by the Lieutenant Governor to stand up and speak. And just one quick aside, I don't know which was more difficult, becoming a doctor or becoming a senator. I can say becoming a senator took 1.5 years of campaigning, whereas, as we all know, becoming a doctor takes a lot more years of work, but you don't have to sit there and campaign and knock on lots of doors. But I'm proud to be here. As you heard, I am a doctor senator. There's only 2 of us in the legislature. Remarkably, both of us are in the Senate, and we both serve on the Public Health Committee, which is a natural fit for me. And I also serve, in addition to many other committees, I also serve on appropriations. When we talk about public health initiatives, then I get to pivot to appropriations, where we get to talk about how do we pay for it all. So it's actually somewhat of a natural fit. But I've been a cancer doctor for many, many years. I continue to practice. That's my day job when I'm not busy doing Senate stuff, and I'm very happy to continue doing that work that I've been doing for over 30 years. I want to say a big thank you to the American Cancer Society Cancer Action Network for hosting today's event and for continuing its strong work it does, advocating for people who have cancer, advocating for people who are cancer survivors, and more We're blessed to have cancer survivors and also advocating for trying to screen people for cancer, many of whom don't even know they might have cancer, including lung cancer. And I do a lot of ordering of CAT scan screening in my practice. I want to thank Yale and the Smilow Cancer Center for hosting today's event. And I also want to recognize the great work in this state that the Connecticut Cancer Partnership does. And I certainly appreciate all of that. As a senator, I get to represent around 100,000 people in Northeast Connecticut. So when we saw some data about Windham County, I represent part of Windham County, and I represent part of Tallinn County, and I get to represent 13 towns. So that certainly keeps me very busy, and I'm proud to advocate for people. We certainly know over the years, and we've heard the earlier presentation, there's been a big renaissance when we talk about cancer care. I remember the days when we didn't have a lot we could do, and now we're blessed by having huge number of different opportunities that we can do to really help care for our patients, but also really individualize that type of care. But one of the things I recognize whenever we celebrate what we've been doing and the success we've achieved, as we all know, there's a lot more work to do to move things forward. And I look forward to working with all of you and everybody else across the state to see what we can do to move things forward and continue to help care for people wherever they are in this state, giving them the timely and fair, equitable access to all of the great care that we're known for here in Connecticut all throughout. I represent a rural part of the state, so I focus a lot on rural health, but I can tell you, even in my rural part of the state, all these types of things we do make available and people can access. And it's because of a lot of effort of all of you and others that allows that to happen. So thank you, for that, and I very much look forward to the work ahead that we can do, including partnering with the American Cancer Society to help more and more people everywhere in this state. We have a great state, a lot of great people, and a lot of great care to be able to provide to them when they need it. This morning, we're going to hear from a distinguished panel of guests, and I'm looking forward to hearing what they have to say and hearing any questions that get raised and the answers to them. We do have several panelists here today, and I'll introduce them. We have Marianne Daves. She's been involved at Yale New Haven Hospital's Cancer Center since 1983, including as an advanced oncology certified nurse. She is currently an acute care nurse practitioner, advanced oncology certified nurse practitioner, and clinical nurse specialist in adult health. In addition, has received various awards and honors, including the Ruth McCorkle Oncology Advanced Practice Provider. She belongs to the Sigma Theta Tau, National Honor Society of Nursing, the Oncology Nursing Society, and the International Association for the Study of Lung Cancer. Another panelist with us today is Lynn Tanoue. Dr. Tanoue is a professor of medicine, vice chair for clinical affairs for the Department of Internal Medicine at the Yale School of Medicine, and director of the lung cancer screening and nodule program here at the Cancer Center Hospital. Has led numerous leadership or has held numerous leadership roles at Yale New Haven Hospital and serves on numerous national committees, including the American College of Chest Physicians, Lung Cancer Guidelines, the writing committee for that, and is a member of the National Comprehensive Cancer Network Lung Cancer Screening Guidelines Committee. We have also with us Dr. Mark Godfrey, who is Director of Bronchoscopy and an Interventional Pulmonologist at Hartford Hospital. He was good enough to step in for Dr. Brian Wang, who could not be here today. Dr. Godfrey was chief resident at Rhode Island Hospital before becoming a clinical fellow in pulmonology and critical care medicine and a fellow in interventional pulmonology at Yale New Haven Hospital. And he joined the Department of Pulmonary Critical Care Medicine and Thoracic Surgery at Hartford Hospital in 2021 and serves as one of the operational leads of the lung cancer screening program at Hartford Healthcare. We also have with us today as a panelist James White, Executive Director, U.S. Medical Oncology, Lung Emerging Tumors and Abraxane for Bristol Myers Squibb. He leads a team responsible for development and execution of in-market medical strategy in support of thoracic and women's cancers across the Bristol-Myers Squibb portfolio, and he brings 16 years of oncology biopharma experience, and prior to joining the industry, he was pediatric critical care clinical pharmacist for Wilson Children's Hospital after completing residency in this specialty at Arnold Palmer Hospital for Children. So very, very proud to have them here and to introduce them today. And if we want to go ahead and begin our panel discussion, happy to have all the panelists come forward. Whatever you want, I'll ask the question. Well, now that we have them all seated and we have them in the hot seats right in front of you all, I'll introduce to speak first and to ask a question. Oh, yes. Marianne Daves, and who's going to give us a presentation. And one of the questions, and this is kind of a general overarching question, is what can be done to improve the quality of care that all cancer patients receive, but also, I may add, deserve to receive? But thank you.
Thank you very much for the introduction. It's such a pleasure to be here, and thank you, everybody, for all the work that you're doing and attention you're giving to lung cancer today. I really appreciate it. So I'm going to talk about some different strategies for how we can help our patients get through this entire journey. And one thing I just want to highlight is a lot of the challenges that our patients have. There's a lot of delayed time to diagnosis, and a lot of that has to do with health inequities and disparities, delayed time to treatment, decreased adherence to some treatments, lack of knowledge, access to resources. As Lucinda mentioned before, there's a significant impact on stigma and shame, and that's not just even for the patient themselves, but it's their caregivers and their family members as well that also experience the stigma of cancer, and that can also lead to delays in treatment and onset of diagnosis. Patients also experience a significant amount of altered physical functioning because of their respiratory status, body image changes in some cases, symptom distress, and then there's also the financial distress that comes along with all this. There's a financial impact of co-pays and traveling and transportation, an impact on their ability to maintain their work schedule, and also an impact on their family members' ability or caregivers' ability to maintain their work schedule. So there's a loss of income there. And also some challenges that we have with some of insurance coverage and getting things authorized and prior authorization. That's certainly an impact and a delay to treatment for many of our patients, and that's one of the things that we need to overcome. So there's some strategies to improve the quality of care patients receive, and some of the things that we can do as providers in the healthcare team. There's the integration of health-related quality of life into our metrics and our outcomes. There's aggressive symptom management, certainly smoking cessation programs and early screening, navigation, and that's coordinated navigation through the cancer trajectory, shared decision-making model, where we had a very big program and spearheaded this through our thoracic oncology program in the past few years and training everybody in shared decision-making model, and also the use of clinical care pathways. So I'm going to focus just very briefly on navigation and the benefits of navigation, and also the use of clinical care pathways for our patients. So really, what is cancer care navigation? Well, it really is rooted in health equity. This is really where that terminology is spearheaded from. It provides appropriate and timely education, both anticipatory guidance, diagnostic and staging procedures, information on disease-specific details and treatment details. It supports shared decision-making, so helping to prioritize what patients' and families' goals are. It assists patients even define what their preferences are, so it can has an impact on decreasing unnecessary testing and treatments if it's not in the patient's preference profile. Also, navigators can assist in the use of decision aids to help move decision-making forward. Certainly, a big role in advocacy for patients, providing emotional support, the coordination of multidisciplinary appointments, which can be very challenging, provide an opportunity for case tracking to ensure completion of care, managing and tracking of symptoms and survivorship needs, and also a bridge to overcoming the barriers to care, such as accessibility to care, financial assistance, insurance challenges, and also assuring language and cultural barriers are overcoming. There's a lot of different methods that this is done. Some organizations use lay people or other patients to provide navigation, but the most successful one with the most successful outcomes are those that use nursing or a healthcare provider to help patients navigate through. So what are the benefits? Well, the benefits: improve rates of screening, first of all, decrease time to patients' first visit with the team, reduce time to diagnosis and treatment, timely diagnostic resolution, improved treatment adherence, higher completion rates for cancer therapies, higher rates of appointment completion, improved health outcomes, improved patient health care literacy, improved satisfaction and quality of life, access to equitable care across the trajectory, improved communication across all of our healthcare team members, and also providing guidance on what are the reliable cancer information sources. There's a lot out there on the net, so how, what is reliable, what is not? How do you gear people towards that reliable information and services? And also provide an opportunity for culturally competent care. And I just wanted to show a model where this really was spearheaded, and this is the Harlem model of patient navigation. And so you really want to make sure that you're starting with outreach, and you don't want these to be happening in silo for patient navigation. This is where people fall through the cracks, and we lose people to follow-up. So there needs to be a coordinated effort from outreach to screening, early detection, diagnosis, treatment phase, and all the way in through the trajectory of whether or not it's end-of-life care or it's survivorship. So this model really serves to be what has been the most successful model for patient navigation. So really increasing those efforts across our health system is of vital importance. The next thing I wanted to focus on is, all right, we navigate people through. How do we make sure that we're following appropriate care for patients to make sure that we're bringing equitable care across our entire network? Yale New Haven Health System and our enterprise started a few years ago with a program of care signature pathways to help assure that the best of care is really available across our entire enterprise for patients of all diagnoses. And we've done these care pathways in a variety of things like cardiovascular care and maternal child health, et cetera. And we're just starting this summer in working in oncology. And so I've taken on a new role to be the program manager for that for oncology across our enterprise. And our three diseases that we're focusing on to start are lung cancer, GI cancers, and breast cancer. And the idea is really to minimize variation across our healthcare centers and across our entire network. So decrease variations in clinical care. It is a patient-centered approach. These are not treatment pathways. These are care pathways. How do you move that patient from the outreach and all the way through the trajectory of their care? It ensures equitable care processes and outcomes in the care that we provide. This might be a little hard to see, but I'm happy to share slides with anybody, but it is patient-focused care that really helps to improve quality and safety by bringing best practices and standards to the patient where they live and not having patients always have to come into the center hub. It provides an opportunity for harm reduction, reportable metrics, and reputable drivers, assures health equity in terms of benchmarking for equitable care across our enterprise. It addresses population health and social determinants of health. It provides an improved patient care experience with education, communication, provides an opportunity also for us to research our outcomes. It improves clinical operations by in many cases, reducing length of stay, readmission rate, improves access to care, and improves care navigation by following appropriate care pathways. And then also a financial impact. So it decreases cost of diagnostic precision by removing unnecessary changes and also enhancing the use of appropriate testing when it is done. And also significant other issues of risk mitigation. So it really has a significant impact across the entire network, both at the patient level and at the operational level. So really, Care Signature brings our principles of what we know, bringing the best research that is available, and then we bring that to all areas of our patients and have an expanded, broad cast out into our network. It really harnesses the evidence, brings the experts together to say, how do we make this actionable for our organization across our state? So it's different to take something that's been published in the research, and then how do you actually make that work for the patients and the residents of our state? It helps us to uncover a lot of variations in quality care and provide safe access to care. And then just in terms of some other strategies for patients, it really is significantly important that patients have access to support groups, social workers, the shared decision-making model, and support foundations to help them navigate through the trajectory of their illness. And additional resources that into survivorship for patients that are really helpful: pulmonary rehab. We need to have them have access to long-term care follow-up, surveillance for potential recurrence, prevention of cancer recurrence, and interventions for the consequences of cancer treatment, such as medical complications, psychosocial distress, and survivorship support groups. So those are just a broad overview of some of the strategies that we can use to help improve overall the patient experience. So, thank you.
Thank you very much for your presentation. And our next panelists that I'll ask a couple questions one by one, I won't bomb you with all of them at once, is Dr. Tanoue. And one question is, what are some barriers you have seen in terms of patients accessing lung cancer prevention and early detection screenings, as well as new innovations? For example, how does geography impact access, and how can disparities be addressed moving forward?
Thanks very much. And thanks to everybody for being here. It's great to see all these faces. Bill and Lucinda and Marianne actually addressed a lot of the barriers that we tend to think about immediately, like geography, rurality, socioeconomic status, navigating the complexity of a healthcare system from the beginning of the journey all the way through. I think, though, a huge barrier is awareness. And if you go to your primary care doctor, patients expect to be screened for breast cancer and prostate cancer and colon cancer. That's sort of part of the everyday medical practice. It's widely accepted, widely practiced, and is considered normal. And lung cancer screening really has not reached that threshold. And so many patients, and in fact many clinicians, are really not aware that lung cancer screening even exists. And that really is a huge contributor to that low bar of, at the present time in Connecticut, 5 to 6% of eligible patients are being screened. And to some extent, that lack of knowledge has to do with the fact that there have been barriers in terms of behavior put in place for lung cancer screening, and specifically the quantification of smoking. And so if you think about breast cancer and colon cancer and prostate cancer, you start screening at a certain age and based on gender, not on a behavior that requires a discussion and compilation of numbers. And Bill, you talked about how do you even calculate the number of pack years. And so I think that awareness that screening is available is the first huge barrier, and the word really needs to get out on the street, because many, many people don't realize that they are actually eligible. So in the US, with the updated United States Preventive Services Task Force recommendation in early 2021, and lots of things that happened during the pandemic sort of got a backseat, and so that's partly why I think this awareness is poor. 14.5 to 15 million Americans are actually eligible for screening, and I would guess that most of them don't know it. So that's the first thing, and I think getting the word out, things like convening people in rooms like this are really important, because hopefully you will throw your pebble in the pond and get out there and spread the word. The second thing is that lung cancer screening sounds so complicated. You need a CT scan. And many people think that's a really bad test, like a MRI. They're going to put me in a box and I'm going to be really scared, or they're going to put an IV and it will hurt. And most people don't understand that CT scan for lung cancer has very little radiation, so the harm there potentially is really minimized, and it takes one breath. So it takes longer to check in for your CT scan than it actually takes to get the scan done. It's actually really simple. So the concept that this is going to be a scary exam is a huge barrier. Having done many mammograms in my life, that's like not exactly fun. But I go and I get it done. Having blood drawn for, PSA isn't fun either. That hurts. And colonoscopy, like, is a big deal. And so when you think about other cancer screenings, there is pain and suffering in those that actually you don't experience with lung cancer screening. So I think that's another big one. What is the test? It's actually really simple. It doesn't hurt, and it takes one breath. Literally, you don't have to even take your clothes off. And then the third thing is cost, and Bill alluded to this. Actually, in the state of Connecticut, lung cancer screening is covered. It's covered by private insurance, by Medicare, and by Medicaid. And that last one is really important because the Medicaid population is actually at the highest risk for lung cancer because of the behavior associated with 80% of lung cancers, which is smoking. That's not true in every state. States that did not accept the Medicaid expansion under the ACA don't have to offer lung cancer screening to Medicaid patients, but fortunately we live in Connecticut where that is not true. But Bill also alluded to cost after the screening, and Polly Sather, who is our lung cancer screening coordinator for the program at Smilow, has heard more than once from patients, I can't afford to have cancer now. My life is too stressful. And they are very aware of the costs that will be inevitable if they get a diagnosis. And so I think that sort of barrier also needs to be overcome, and that's going to be overcome really at a policy level at the federal, at policy changes at the federal level. And so I think that the biggest thing we can do to improve our rates of lung cancer screening is improve awareness. Make it clear it's easy, make it clear it's covered, make it accessible in all geographies, since every town at this point should have a CT scanner. And if we can make awareness rise to a higher level, I think we will get our numbers up and save more patients from mortality from lung cancer.
Well, thank you. I agree with you. Awareness is a big issue. I lose track of how many men I see each week who, one of the first things they want me to order is a PSA. And then when I ask them about their smoking and their smoking, they seem surprised when I talk about lung cancer screening and I'm ordering a CAT scan for them. So even amongst the patient population, awareness is a big thing we need to continue to roll out and remind them, and especially if they're going to be seeing primary care doctors who may not be as aware of this as those of us who are cancer doctors, making certain they advocate for themselves and ask, do I qualify for lung cancer screening? And I remind my patients about that as well. But thank you. Just want to go to Dr. Godfrey for a question. And question I'll put you on the spot on is, what are the current limitations of lung cancer screenings, and where do you see the technology in 5 years or even beyond 5 years?
Well, thank you. And thanks everyone for having me. It's good to see some old friends here. So the way I think about technology in terms of lung cancer screening is in a couple of buckets. One of them is sort of the nuts and bolts in the trenches work of maintaining a screening program, because when you're doing that at scale, something like an Excel sheet becomes pretty untenable. And so you need a way to use technology, to use your EMR to identify patients, to track them longitudinally, to automate some of your routine communications. You want to be submitting data about your screening program to CMS, to the American College of Radiology, things like that. You also need to be able to look at your own screening program's activity and effectiveness, and to generate some analytics to find ways that you can continue to improve. And so all of that, there are commercial software packages that help with that. There are tools within the EMR that help with that. But that is, I think, a big part of lung cancer screening. That's in place now. Where I think the future of technology in lung cancer screening is going to go is in personalized risk assessments. So, the age, pack years, quit date kind of one-size-fits-all approach. There are models that exist now that can sort of quantify patient risk a little more individually. And then in looking at the data that we're getting from lung cancer screening CTs, we obviously have experienced radiologists who are looking at all of these, but there are new approaches using radiomics or even deep learning, where they're taking the volumetric data from some of our foundational lung cancer screening trials and developing models that will highlight sort of low risk by lung rads scans that have something worrisome on them, and we can maybe potentially triage an individual follow-up interval for those types of scans. And so that, I think, is going to be where things go in the next few years. And then ideally, some sort of biomarker that we could combine with the image information would sort of be the pie in the sky dream, but we're not there yet.
Thank you. And I guess we'll all eagerly await what will happen. And even though we're talking about the next 5 years, as we know, the advances seem to happen literally like month by month, especially as this technology just moves forward incredible. So it's very exciting to see all of that play out in real time to help patients right there on the spot. I'm going to pivot to James White to ask you a question. What do you see as the biggest challenges to bringing new therapies to market? And I'm going to tag team that with an additional part, which is what is needed to continue to promote new advances. We know there's lots of advances going on, but what can we do to continue to promote that so we can continue to have new things for our patients?
Thank you very much for the question, Dr. Senator Gordon. I want to also thank you, everybody, for letting me be part of the conversation today. And as I thought about this question, I really wanted to give an honest answer. And the honest answer to me for what is the biggest single thing preventing us from bringing things, new modalities, is something actually Dr. Herbst touched on earlier today. It's an antiquated trial design concept in terms of how we actually develop drugs. We need to be a little bit more flexible of thought in terms of how we bring drugs to market and how we develop through the program. From discovery to the time a molecule is actually available and approved by a regulatory therapy is a long and arduous process fraught with peril around it. And so to make sure that we pharma, get from the beginning to the end, we try to de-risk that as much as possible by looking for the biggest gaps. Sometimes that doesn't serve what we actually need as a society, however. And so I think pragmatic trial design with innovative outcome measurements that are agreed upon not only by pharma, but the investigators and the regulatory authorities is what's going to take us to that next step, especially as science moves so fast now. The space becomes so competitive, investment becomes so concerned about what's going on that we give up on programs too early where there probably is actually benefit. And so to be able to move forward from the traditional, let's look at it in refractory disease, in metastatic disease, and then early disease, how do we actually create a scenario where we can actually look across the need of a patient in any one cancer, especially in lung cancer where the need is so great, and be able to look at a portfolio of options as opposed to just one company's options all at one time. And so I think that kind of pragmatic, lung pragmatica study, for example, is a great example. Is the only way we're actually going to be able to move with the speed we need to be able to keep with the technology that's going on today. And I'm sorry, the second part of your question was?
Was what's needed to continue to promote the new advances?
What we're doing today, being in conversation with each other, being an open and transparent conversation, trying to share ideas and make sure that we're driving awareness into the population as a group, using our collective resources to make awareness at a level to where patients feel comfortable having these conversations. The blame, shame, stigma is very real. We see it when we're trying to enroll for clinical trials. And so the fact that we all meet on a Thursday morning in New Haven when it's burr cold outside, to have these conversations, I think, is the first and probably most important step in how we continue to move this forward. And so that would be my answer to that.
Great, thank you. Thank you. So certainly a lot more work to continue to do. So hence why we're here today. So thank you. I know we still have some time for some further questions. So one of the questions, if I could, just pivoting back to Dr. Tanoue, is for lung cancer patients, what do you see as far as how they could benefit from genetic testing and the targeted therapies? But what I would really like to focus on is how do you see those types of innovations such as biomarker testing impacting lung cancer early detection, but also just not detecting these cancers, but then having that information, then being able to go ahead and see what we could do to pivot them into the treatment pathways?
How much time do I have?
I know it's a big question, but
So I'm glad you asked again about biomarkers. So think about an iceberg, right? There's a little bit of the iceberg floating above the ocean that you can see. And then there's this huge part of the iceberg underneath that you can't see. So that in terms of screening and biomarkers, the little tip of the iceberg that we're looking at right now are patients who meet the criteria for screening Bill talked about, ages 50 to 80, who have smoked 20 pack years total and are currently smoking or quit within the past 15 years. We know that those people are at high risk and they should be screened. That's not using biomarkers, that's just using patient demographics. And so we really should be screening the people in that huge part of the iceberg we can't see under the water, but we can't screen all 300 plus million Americans who are over the age of 18 just because they're over the age of 18. Certainly not with CT scan, which is, the tool we've got now, but is pretty crude, costs a lot of money, and invokes a little bit of radiation, but cumulative over a lifetime might become significant. And so that's really where biomarkers, I think, are going to be important. And so there are biomarkers that are being marketed out there. They tend not to be a single test. They're tests that are looking at like 50 genes. The problem is we don't really know what to do with that information yet. If you have one gene that's abnormal, should you be screened for the rest of your life? Is your risk really sufficient on the basis of that one abnormality to say you're at high enough risk to justify CT screening? And I think that, though, is where the future is, and it's really not that far away. The prototype of this, obviously, is the BRCA gene for breast cancer, where if you are BRCA positive, and generally you know that because somebody else in your family had breast cancer, and so you went and got tested, your screening is actually different than if you don't have that genetic marker. And so at a point in the not-too-distant future, when we have that sort of blood, breath, sputum, a non-invasive specimen biomarker, we could potentially screen the entire adult population of the U.S. at less cost, less risk, less harm, less pain and suffering to the patient for what is a preventive intervention, and figure out who in that big part of the iceberg should be getting lung cancer screen. And then to pick up on what Mark talked about in terms of high-risk prediction based on models, we have that now. Can we apply these models that look not just at age and smoking, but gender, family history, occupational exposures like asbestos, education level, and so on? Can we use those now to pick out a population that is that should be screened? And the answer is a qualified yes. The yes is you can pick out the population. The challenge is will it be covered by insurance? And this brings out disparities because we have populations who will say, I will pay out of pocket for that to have the scan done if you tell me I'm at high enough risk. And we have a lot of people who cannot pay out of pocket for that scan, and creating even wider gaps and disparities is something obviously we don't want to do. we also don't want not to do a screen that we think might save somebody's life. So people who are in our positions are facing this dilemma, and it becomes an individualized decision and a discussion with the patient. And so I think that huge fat part of the iceberg that we know is there, where a lot of people with lung cancer risk live and a lot of people with lung cancer will die, is our challenge. And we have to, at some point, be able to address that huge population that is not eligible for screening now. And I think biomarkers is the way to that.
Thank you. And I'll follow up. We still have a little bit of time for some additional question, but following up as far as what we can do to reach out to people who are eligible for screening. As we've heard, a very small percentage, unfortunately, are given that opportunity even though they're eligible. Let me just ask Dr. Godfrey, as far as what do you see some of the ways we might be able to better address basically the gaps we have, just not gaps with regards to try to make awareness out there for people and for the healthcare system, but different communities where there's, disparities with regards to socioeconomics, geography, those types of things, language barriers. What can we do to try to better address these types of gaps? But also we know there's additional financial gaps as well that people, worry about. I can tell you as a doctor senator, I wear one hat as a doctor, wanted to make certain we can promote lung cancer screening, but then I wear a hat as a senator. What can we do from a public policy point of view to really make that happen across the state?
Yeah, it's tough because, again, the exposure that we're interested in, which is tobacco use, is overlies a lot of these other disparities in terms of educational level, in terms of socioeconomic status, in terms of geography. And so it's kind of all intermixed. I sort of wish I had a really easy 2-minute solution to that problem. It's a thorny one. I think part of it is, as Lynn was getting at, time. Lung cancer screening relatively is a new screening topic. It takes time for people to have a loved one who had a lung cancer screening CT and talks to them about it at the Thanksgiving dinner table. It takes time for providers to become aware. And so the best thing that we can do is keep doing what we're doing now and fighting for that and working for ways to make it more and more accessible and less stigmatized. The only thing that I'll say, I guess, is it's not something that you can do from far away. I mean, you really have to go to people who are in the community, who are community leaders, who work with nonprofits. You have to go to people who are, faith leaders in communities. You have to engage people like that to really move the needle in a big way. It's not something that you can do with, an ad campaign as much as we'd like it. Marianne, do you have anything to add? I mean, I know this is your wheelhouse too.
I think that's really key, is getting out to the communities so that you have a culturally appropriate messaging that's delivered. So working with small advocacy groups in each of the communities is probably the best way to make a personal message to the patients that are at highest risk.
Thank you. Well, I know where we stand with the clock. I know we have tons and tons more questions, but we won't be able to have the time for it all. But I want to say a big thank you to our panelists for being here today and talking with us. Thank you very much. And I'll turn the microphone back over to Bill.
Well, thank you so much, Dr. Senator Gordon. And to our great panelists, let's give them another hand for really sharing. Dr. Tanoue, I think I'll make your day here. A lot of people have talked about biomarker testing. It is coming to a state near you, right here. For the American Cancer Society Cancer Action Network, it is our #1 priority nationwide. 13 states have already passed mandating coverage for biomarker testing. A 14th, a little-known state, New York, passed it in June. And if anybody knows Governor Hochul, please see me after this, because we've been working with her for 6 months, and she still has not signed the bill. And we're really becoming impatient for this because the red states of Georgia, Kentucky, Texas have passed and enacted biomarker testing coverage. And Governor Hochul is the one person in New York standing in the way. And by the way, that bill passed almost unanimously. Only 2 out of 212 lawmakers voted against it. And if you've ever been in any of the state houses, especially in New York, they can't agree that it's 10 o'clock when it's 10 o'clock. So they all agreed that it was needed to be passed. So thank you so much. You can join ACS CAN. And our efforts in the fight against cancer, and use your voice to stand for others. Please visit our state webpage. It's very easy. It's fightcancer.org. fightcancer.org. And if you do /Connecticut, you'll get the Connecticut information, or if you just go to fightcancer.org, at the top, it'll say where you can, it'll allow you to choose any state to find out kind of like the most information, the most current information that we're working on there. You also can donate. We can't do the work we do without money for this mission. There's no mission without the money, right? And then you can also take part in our advocacy efforts moving forward, which do not cost anything. You don't have to become a member to do it. You can be a member just with $10. That would make our day. But also, most important is constituents raising their voices and letting those the decision makers know that you care about these bills, whatever they are, lung cancer screening, biomarker testing, whatever. Before we conclude today's program, we want to share that with you that in September we lost a titan of cancer advocacy and fundraising for ACS CAN here in Connecticut, Dave Coach Koch. Coach had been an advocate and volunteer. It's hard when we lose people, and we see this all the time, so I'm sorry, but and I've practiced this and I was able to kind of keep it together. But I had the pleasure of getting to know him and sharing texts and throughout his journey, and he was just an incredible advocate for us. He joined the American Cancer Society since the 1990s, and he was one of the very first members of ACS CAN. So his passing from cancer has left a deep hole in our hearts, and we will always remember his strength, his inspiration, and his tenacity. To further commemorate Coach's impact, we're announcing today that moving forward, this event will now be called the Dave Coach Koch ACS CAN Connecticut Public Policy Forum. We love you, Coach, and we want to extend our deepest sympathies to his family and friends. And finally, as we conclude today's program, I'd like to thank our wonderful host and Emily in the back, who has been kind of like the air traffic controller for us. Our presenting sponsor, Yale Cancer Center, Smilow Hospital. Thank you so much for hosting us. Let's give Yale and Smilow a round of applause with our team. And then our gold sponsors, Bristol Myers Squibb and Hartford Healthcare. Our silver sponsors, Amgen, GlaxoSmithKline, I know them as GSK, Johnson & Johnson, Pfizer, and Pharma. And finally, our bronze sponsors, Astellas, Genentech, Merck, and Sanofi. Thank you so much for your partnership in this. And I also want to say a huge thank you to our Connecticut-based team here, Bright Johnson, who's our Government Relations Director for Connecticut in the back, who many of you know. And we couldn't do the work without our grassroots manager, our senior grassroots manager, Natalie Shirtliff, who's in the front here. So thank you to our Connecticut team. And then on behalf of ACS CAN, our thanks go again to our speakers and our sponsors. Thanks go out to each and every one of you here for making an impact, for your support, your generosity, and your commitment to furthering the fight against cancer and working on behalf of those suffering from this disease. We look forward to your continued collaboration. We wish you a wonderful and peaceful holiday season and a happy new year, and have a wonderful day. Thanks for joining us today.